Okay, I'm just going to briefly show you a case. This is a 78 years old, very fragile lady, weighing only 33 kgs with previous abdominal surgery. So this lady presented with large infrarenal abdominal aortic aneurysm with impending rupture and ongoing severe abdominal pain. We took her after the CT for an angiogram, and the coronaries were normal, luckily. This is the left and the right coronary shots. And this is the abdominal aortogram showing infrarenal aneurysm and also a saccular aneurysm at the aortic bifurcation. This is the CT scan. It's a run-through CT scan. You can see that the aneurysm starts just below the infrarenal area, and then there is a large saccular aneurysm at the level of aortic bifurcation. What we also see here is the bifurcation is very narrow. It's only about 9 or 10 millimeter in diameter, and both the excess vessels, femorals, are very small. They are 4.5 to 5 millimeter. One side 4.5, and the other side is 5 millimeter. So this is a lady which came to us. We wanted to treat this, and we had no options there was no stent graft which we could have deployed. So we had to have an indigenous approach to treat this because the surgeons were not ready to operate upon this patient. So what we did, we thought about it. So we used 2 Ventana atrium stent grafts, and we telescoped one into the other one, and then converted this into a ioto uni-iliac stent graft on table. Then we went on the other side and put an Amplatzer device to occlude the left common iliac vessel, and then followed it with a fem-fem bypass on the cath table itself. So this is the first stent graft, the atrium stent graft, which is 8 millimeter into 61 millimeter, and we just deployed this graft so that it has a distal landing zone which is sealed. And after this, if you see, the distal zone is sealed, but it is well into the aneurysmal cavity. And then we put in another stent graft, telescope through this, and this we positioned it exactly, keeping the pigtail shot from injection from above, exactly sort of touching the renal artery, a millimeter below the right renal artery, which was the lower renal artery. Then after that, this was a 16 millimeter into 61 millimeter stent graft, and then we dilated this. And while we were doing this, we kept on injecting from the top so that we are not occluding the renal arteries. And then we dilated it to the nominal pressures, and then went down and sort of tapered this into from aorta 16 millimeter down to 9 or 10 millimeter diameter. So this is a 16 millimeter balloon which is dilating the proximal part and the distal part of the lower stent. Once we did this, we found that there was an type 1 endoleak, and it required further dilatation. So we went ahead with a 18 millimeter balloon, again doing the same procedure, and sealed the type 1 endoleak at the top. And then we had another balloon dilatation at the lower part and at the point of overlap. And then went from the left side, we punctured the left femoral artery and put in a Amplatzer 3 plug there. So this is the Amplatzer plug. And then we were okay that it was of adequate size. We removed the cable. This is the final result which we got. There was no endoleak. We converted using 2 Ventana grafts. We made an indigenous ioto uni-iliac stent graft, and we occluded the left common iliac artery to prevent retrograde filling. So we could treat this, and after this probably is a good case because there was a surgical refusal because the patient had previous abdominal surgery. It was high risk for rupture because the patient was having an impending rupture with ongoing abdominal pain. We could use 2 antenna grafts to circumvent this problem, and we sealed the left common iliac artery with Emplatzer plug. And this was especially difficult because the aorta size of the aorta at the level of bifurcation was only 9 millimeter, and the femoral vessels were very small. This is the FEM-FEM procedure which we did on the cath table itself. And the patient was discharged on the 6th day with aspirin and clopidogrel. She was followed for 2 years with no CT evidence of endoleak, stent migration, or aneurysm expansion. So this is probably a unique way of tackling such situations, which are very rare. This is the patient after 2 years. Thank you very much.
Excellent result, excellent case.
I could congratulate you for what you have done about this case. Just can you clarify me, you use the atrium stents?
Yes.
These are covered stents? Or?
These are covered stents. These are covered stents which has the PTFE. The stent is embedded in the PTFE, so you can expand it to any diameter and they don't break.
Yes.
So we first sealed the lower vessel, it corresponded to the iliac vessel size, and then put another one inside that which put it just below the renal, and then tapered it according to the size of the vessels. So it's pretty simple, and we could work with just 12 French sheet, maybe 10 French sheet.
That's a very good result. Yeah. And I think the Cook is developing 14 French sheet, isn't it? Low profile.
The sheet?
Yes.
The Cook, we use the Cook sheet here, 10 French Cook sheet, but we have sheets up to 14 millimeter from Cook.
He's asking for AAA.
For AAA repair, stent graft.
Cook is coming out of this.
14
Yes,
French.
Cook is coming with a 12 French, and I think
14 French.
Cordis is coming with a 13 French system as well.
Thank you.
Okay, thank you. We have to stop. Maybe you have something to say.